Okay, good afternoon, everyone. This is the second abstract session of the day. I'm Guy Grableski from the University of Wisconsin. This is Bami Lee from Stanford. We have a very interesting group of talks today. I think people are slowly coming in after lunch, but we have to get started in the interest of time. The first talk is entitled Postpone or Immediate Drainage of Infected Necrotizing Pancreatitis, Pointer, a multi-center randomized trial by Mark Besselink and colleagues from Amsterdam, UMC. Mark, if you're here. This one's postponed, I apologize.
I want to thank the organizers for inviting me to present on the Pointer trial on postponed or immediate drainage of infected necrotizing pancreatitis. I have no disclosures. The Pointer trial is published several weeks ago in the New England Journal of Medicine, and it addresses this clinical scenario. Imagine this is your patient, a female, 62 years old, with infected necrotizing pancreatitis on the ward, is unwell, high fevers. You see here impacted gas bubbles on the scan, collection is not yet walled off, some wall here, but not completely walled off. 3 weeks out, what would you do? Well, what do the guidelines say? Well, the guidelines say if you intervene, use a minimally invasive step-up approach and try to postpone intervention until the stage of walled-off necrosis. Well, this may not be so easy. Just imagine this clinical scenario of this patient that we just discussed. So there is an ongoing debate regarding the optimal timing of intervention. So in a survey we did, actually 45% of experts said they prefer immediate catheter drainage, so no postponing. Some studies have suggested that earlier intervention leads to better outcomes. So there is an hypothesis that's saying that encapsulation, so walled-off necrosis, may be less important if you intervene minimally invasively, and that potentially immediate catheter drainage may prevent worsening of ongoing sepsis. So the research question of the Pointer trial is immediate catheter drainage, so within 24 hours of the diagnosis, in patients with infected necrotizing pancreatitis, superior to the current approach in which we postpone catheter drainage. So Pointer trial, patients with infected necrosis randomized to immediate catheter drainage within 24 hours or postpone drainage using antibiotics to try to reach the stage of walled-off necrosis. The diagnosis of infected necrosis was either gas on a CT scan or a positive Gram-R culture, and after 2 weeks, clinical suspicion was also sufficient and a catheter drainage had to be technically feasible. If the pancreatitis was ongoing for more than 35 days, or patient needed emergency laparotomy or had an earlier intervention or documented chronic pancreatitis, they were excluded. Comprehensive complication index, so the combination of all morbidity was the primary endpoint. So the results. 544 patients were screened. Most of them did not meet the inclusion criteria, mostly had no infected necrosis or sterile necrosis. Some patients declined to participate, so we were able to randomize 104 patients, 55 versus 49. In 4 of these, drainage was delayed. In this patient, drainage could not be delayed, but all of these were analyzed according to the intention to treat principle in the group they were randomized to. So baseline characteristics, age, male sex, ASA score, no differences between the groups. Admitted to ICU, 1 in 4 patients, organ failure, no significant differences as well. As was SIRS, more than 80% of patients. Timing, 24 days between onset of symptoms and drainage versus 29, so could be delayed. And since randomization, 1 day in the immediate group versus 9, so 8 more days in the postponed group. And then the primary endpoint, the comprehensive complication index. No significant differences, actually a bit worse in the immediate group, but this was not statistically significant. Then secondary endpoints, mortality 11 versus 10%, not different. New onset organ failure, although this seems a bit lower, not significant. Bleeding, perforation, fistula, hernia, wound infection, all did not differ significantly between the groups. Exocrine and endocrine insufficiency, again, no differences between the groups. Days in ICU, days in hospital, actually here you see 13 days, so nearly 2 weeks longer hospital stay if you drain immediately. Total number of interventions actually higher in the immediate group, 4 versus 1, significant. Total number of drainage procedures, also higher, and the total number of necrosectomies, also higher. So if you drain immediately, it leads to more work, more drainage, more necrosectomy procedures. You see that also here in the postponed catheter drainage group, actually nearly 40%, 39% required no drainage procedure at all. And then if you look at the sickest patients, so the patients who have organ failure at the time they were randomized, and here also no significant difference. It was a bit lower, but not statistically significant between immediate and postponed catheter drainage. So, the chairman, ladies and gentlemen, I'd like to conclude that in patients with infected necrotizing pancreatitis, the POINTER trial did not show superiority of immediate drainage compared to postponed catheter drainage. And with a postponed drainage approach, more than 1/3 of patients may be treated with antibiotics alone. I want to thank all these participating centers and would like to thank you for your attention. Antibiotics alone. I want to thank all these participating centers and would like to thank you for your
So Dr.
attention.
Besserling is joining for the Q&A session. So please.
Antibiotics alone. I want to thank all these participating centers and would like to thank you for your
So Dr. Besserling is joining for the Q&A session. So please.
Thank you. All these participating centers and would like to thank you for your
So Dr. Besserling is joining for the Q&A session. So please.
Vikas Dudeja from UAB, Margaret study.
So Dr.
So the
Besserling
time
is
interval
joining
between
for the Q&A
the
session.
presentation
So
and
please,
the earliest drainage in the immediate group,
Vikas Dudeja from UAB, Margaret
immediate group is also not very different in the immediate and postponed intervention group. It was not a very big difference. So like it was 20 days in the immediate group and I think 24 in the postponed group.
Yeah, thank you. Can you hear me?
So like it was 20 days in the immediate group and I think 24 in the postponed group.
Sorry, there seems to be a problem with the connection. I keep on hearing the same feed over and over again. Sorry for that. Can you hear me like this? Connection, I keep on hearing the same feed over and over again. Sorry for that. Can you hear me like this?
It's better that we move on, if you don't mind, because we're running short on time.
That's okay. Thank you very much. The sound is better now, so I could answer quickly the question if you like.
It's better that we move on, if you don't mind, because
no problem. Thank you.
Short on time.
That's okay. Thank you very much. The sound is better now,
Okay,
so I could answer
so
quickly
we
the
will
question
move
if you
on
like.
to the next speaker. Next speaker
on,
is Olivia Cheng
if you
Chai
don't mind,
from
because-
Stanford
No problem, thank you.
University.
She's going to talk about systems approach reveals therapeutic role for retinoids in asparaginase-associated pancreatitis.
Next speaker is Olivia Cheng-Chai from Stanford University. She's going to talk about systems approach reveals
people in person after almost 2 years. I hope everyone is staying well and staying healthy. I'm Olivia Chai, and I work with Dr. Sohail Hussain at Stanford University. This morning, we heard 2 wonderful talks from Sohail and Anil. Now, I'm going to discuss with you how we use a systems approach to identify a therapeutic role for vitamin A in asparaginase-associated pancreatitis. Here is my disclosure. Asparaginase is a crucial chemotherapeutic agent in the treatment of acute lymphocytic leukemia, the most common cancer in children and young adults. The use of asparaginase together with other chemotherapeutic agents has transformed the overall survival rate from 20% to more than 90%. One challenge with asparaginase is the association with pancreatitis. Asparaginase-associated pancreatitis, AAP, is usually a more severe form of pancreatitis and one of the most common reasons for therapy interruption. The direct mechanism of AAP is still largely unknown, and there is a major need to decipher the mechanisms. The objective of this study is to identify factors that impact AAP with a systems approach, and we began with connectivity map analysis. It is an approach to compare transcriptional expression data from a disease with those from in silico treatment with proteobases. In this case, a library of more than 3,000 small molecules. We are looking for small molecules to reverse the upregulated gene signatures from asparaginase, as shown in blue in the heat map. And we used 2 data sets for the analysis, and we were surprised to find that several vitamin A analogs are among the top hits to reverse the upregulated gene signature from asparaginase or in the pancreas. Here is the brief introduction of vitamin A. Vitamin A derives from preformed vitamin A or provitamin A carotenoids. Retinoids refers to all vitamin A analogs. Through ligand binding to the receptors, retinoids affect gene expression at the transcription level, therefore has a profound effect on biological functions. With the preliminary finding from the connectivity map analysis, we then examined more than 70 million electronic health records using China X to establish the relationship between vitamin A exposure and the risk of AAP. There were 2 cohorts. Patients administered asparaginase and with or without vitamin A exposure, as shown on the top. After matching, there were 500 patients in each cohort, and there was a 50% reduction in acute pancreatitis. The analysis from the FDA Adverse Event Reporting System FAERS and ARIAS-MI further supplemented the finding that vitamin A exposure reduced the risk of AAP. From calculating the safety signal as shown on the heat map, that we found that vitamin A appears to mitigate AAP. The combined safety signal for the 2 cohorts are shown on the right. The strengths and the limitation of using big data are listed here. Now I'm going to share with you that a case control metabolomic study as the validation method. We performed a global metabolomic study of the plasma samples from a well-matched case control design from the Dana-Farber Cancer Institute ALL Consortium. In the control cohorts, there were 26 ALL patients did not developed pancreatitis after asparaginase. And in the case cohort, there were 24 cases developed pancreatitis within 9 months after the first dose of asparaginase, the induction therapy. The plasma sample 1 was collected before the exposure to asparaginase, and the plasma sample 2 was collected after the induction therapy. We also have the dietary intake information obtained from the same time point. A total of 422 metabolites were detected. We calculated the ratio between plasma sample 2 to plasma sample 1 for each metabolite to see the change. We then compare the difference between the pancreatitis cases and the control. Here we observe there are 3 carotenoid diol isomers, which are carotenoids, was significantly reduced in the pancreatitis cases. And provitamin A carotenoid beta chrysotenzine and vitamin A retinoid are also among the top hits. Pathway enrichment analysis also demonstrated that carotenoid and retinoid metabolism pathway as a top hit. As I mentioned, that we also have dietary intake information. Food frequency questionnaire was given at the baseline and after induction therapy to record the previous 1 month's dietary information. And there was no difference in the intake of vitamin A at the baseline, but there was a reduction of the vitamin A intake after induction therapy. RAE is a compositive measurement for vitamin A activity. Although it did not reach the significance, there was a reduction. So we hypothesize that ALL patients who take asparaginase are predisposed to lower vitamin A levels. If the patients have lower vitamin A intake that pushes them beyond a certain threshold to develop pancreatitis. Patients in the clinical trial, they administered with other chemotherapeutic agents. So our next question is, does asparaginase as a single agent lead to a reduction in retinoids? Our mouse data demonstrated that asparaginase reduced circulating and hepatic retinoid, as shown here. I would like to conclude our approach and finding in these slides that we took a system approach to combine both patient and preclinical samples to uncover that carotenoids and retinoids as a normal biomarkers to predict AAP. I would like to thank all the collaborations, and I wish I have more time to acknowledge all of them. We have several people here with us today. My son is here, Neil and Sohail, and we also thank Dana-Farber Cancer Institute for providing the patient samples and all other collaborators. And I'm happy to take any questions. Thank you.
Thank you, Olivia. The paper is open to Q&A.
Vikas, Tudeja, we really enjoyed your study and really want to commend your group for looking at all the drug-induced pancreatitis and how it happens. The question I have is the effect that you see that the vitamin, so is decreased level of vitamin A anyway important for the effect of asparaginase? In the sense, is the efficacy of this drug any different between the groups which have high or low levels of vitamin A in the serum? Do you have any information on that?
None of that we know of that. Vitamin A, the level, plasma level affect the treatment outcome for the ALL patient.
Yeah.
Yes.
Because that will be something good to see, that is the drug somehow affecting the vitamin A levels and it's part of its mechanism, and is the efficacy, because once we start giving back vitamin A, will the efficacy go down? So
yes, thank you.
Very nice presentation, thank you. I'm sure you looked at the literature, if there's any data on vitamin A and pancreatitis in animal models, people tried to. What did you find?
So far, we haven't found a lot of like a comprehensive experimental, but we plan to use like a genetic mouse model and also like give mouse, feed them with vitamin A to test whether or not they can rescue the pancreas. That is our next must-to-do list.
In a simplest term, what's the model? Vitamin A is bad for pancreatitis or it's good for pancreatitis?
Yes.
Which one?
Oh, sorry.
Sorry, you're asking a question about your own presentation?
I ask permission.
Go ahead.
Well, with permission from the moderators.
Quickly, please.
Yes, and briefly. So there is, Olivia, as you know, there is some data which is actually somewhat characterized about vitamin A in chronic pancreatitis and the role of stellate cells and
yes.
vitamin A containing cells, such as stellate cells, and their depletion. But this is the first for acute pancreatitis, to our knowledge. And so that's interesting, and it may tell about the role of stellate cells in acute inflammation. We think that this is probably not cell intrinsic, just based on some additional data that we haven't discussed. But regarding the question about drugs affecting the efficacy of treatment of ALL, such as vitamin A analogs, I think what we've uncovered here is that it may be as simple as diet. And this was also surprising. The patients who developed pancreatitis with asparaginase just took less vitamin A. And so it may be as simple as vitamin A supplementation. And while that in and of itself might be related to efficacy, it's probably unlikely, and there's some data to suggest that it wouldn't be.
Yeah, just a real quick comment. The stellate cells in the pancreas are much like the liver. They contain very, very large amounts of vitamin A. When there's a drop in serum retinoids, that means that the storage is quite depleted. And it makes me wonder whether or not the asparaginase is either causing the stellate cells to dump their vitamin A or impairing their collection of it for storage.
Thank you.
Okay, next talk is by Maya Faig. I apologize if I got that wrong. From Aalborg University Hospital, evidence for multiple and overlapping pain mechanistic factors in patients with chronic pancreatitis. Is it both the plumbing and the wiring? Maya.
Thank you. Good afternoon, everybody. On behalf of myself and our collaborator at PQSC Consortium, I would like to thank the APA for the opportunity to present our research. I have no disclosures. Painful chronic pancreatitis affects approximately 80 to 90% of patients and associated with lower quality of life and higher rates of disability, and it's difficult to evaluate and treat. There are 4 determinants for all pains: nociception, which is signals arriving into the central nervous system through the activation of sensory afferent nerves; perception, which is pain processing; suffering, which includes emotion, cognition, social behaviors, and also it can also be galvanic skin responses; and pain behavior, which can include grimacing, groaning, laying in a supine or a fetal position. Also, there are multiple factors that have been implicated in painful chronic pancreatitis, which include intraductal hypertension due to obstruction, psychological distress, and sensory testing showing abnormal pain processing. However, it is unknown if these factors overlap and have cumulative effect on symptoms and quality of life. The aims of this study were to determine the proportion of patients with pancreatic ductal obstruction, widespread hyperalgesia, which is indicative of neural sensitization and abnormal pain processing, and psychological distress. To determine the overlap of pain-related factors in individual patients, to determine whether the presence of one or more of these factors influence pain-reported outcomes, and to determine whether the different pain-related factors were independently and directly associated with patient-reported outcome. We performed a multi-center cross-sectional study on over than 200 patients with definite chronic pancreatitis, and we assessed patients for pancreatic ductal obstruction. We included patients referred for decompression of pancreatic ductal obstruction seen on CT and/or MRI imaging. We assessed psychological distress by using hospital anxiety and depression scale and pain catastrophizing scale. We also assessed the patient-reported outcome using pain symptom severity, using modified brief pain inventory short form test, and we assessed quality of life using EORTC-QL-QC30. All of our patients underwent pancreatic quantitative sensory testing. Chronic pancreatitis defined as definite chronic pancreatitis per Mannheim criteria. And this is our study inclusion and exclusion flowchart. We excluded the patient who had, who did not fulfill criteria for definite chronic pancreatitis, who did not have cross-sectional imaging within the 12 months from their sensory testing, patient undergoing any intervention between imaging and PQST testing, patient who had prior surgery interfering with sensory testing, and also patient who had incomplete information following the chart review. We included 201 patients in our final study cohort and then excluded another 21 patients with missing data for psychiatric comorbidity. And finally, we included 180 patients in our cohort that they had all the parameters that we wanted to assess. Here we have demographic and clinical characteristic of our patient with chronic pancreatitis. Majority of our patients were male, and more than 80% of our patients were white. The mean duration of CP-related pain was 8.7 years. And this is our pain pattern. And majority of our patients had constant pain at the time of PQST sensory testing. This table shows prevalence and overlap of pain-related factors. There is an association between the pain-reported outcome measures and one of the pain-related outcomes, including PD decompression, widespread hyperalgesia, and psychological distress, including anxiety, depression, and pain catastrophizing. In this figure, you can see proportion of patients with pain-related factors. On the left side is proportion of patients with pain-related factors relevant for pain severity, pain interference, and quality of life. And on the right graph, you can see proportion of patients with different number of pain-related factors from the 0 factor to 5 factors. And here we can see overlap between pain-related factors in patients with chronic pancreatitis. 24% of our patients had no pain-related factors. We looked at linear trend analysis of number of pain mechanistic factors and patient-reported outcomes. We found that there is a linear increase in both pain severity on the left side and interference on the right side with an increasing number of patient-related factors. And there is also a ceiling effect if a patient had more than two or more than two pain-related factors. Also, there was a linear decrease in quality of life and functional scores with increasing number of pain-related factors. We also look at multivariable regression analysis of patient-reported outcome and pain mechanistic factor. Most notable finding was psychological distress was independently associated with pain-reported outcome and also quality of life. In conclusion, majority of patients with chronic pancreatitis have multiple pain-related factors that have cumulative effect on pain symptom and quality of life. Patients with painful chronic pancreatitis should undergo detailed clinical evaluation, including cross-sectional imaging, neurosensory testing, and a screening for psychological distress. I would like to thank the Pancreatic QSD Consortium, especially Dr. Osborne Drews and Dr. Soren Olsen that were not able to make to the meeting, and also our other collaborators at University of Pittsburgh School of Medicine, Indiana University School of Medicine, the Ohio State University School of Medicine, and All India Institute of Medical Sciences. Thank you. I'll take any questions.
Questions?
Maybe I'll just yell.
Go ahead.
As you're looking at these different factors which are associated with pain, some are psychological factors, some are anatomic factors, do they all have the same weight? Do they contribute equally to the reduction in quality of life, or are some of these dominant over the others in terms of their relative contribution?
So let me, can I go back and show a table? I don't know if I can go back and show the table, but there are different weight to it. We treated them all equally and give them a weight by, yeah, let me just, okay. I think we can see better in this table. So we on the left side, all these are all the patient-reported outcomes measure, and on the top section, you can see the different pain-related anatomic and sensory testing, and then we combine them, and they were actually treated equally, but and I think, but the partial effect being taken into the account in the analysis.
Well, if there's no other questions, we'll move on to the next talk. Very nice talk.
Our next speaker is George Bayer from LMU University Hospital Munich. Chronic pancreatitis prognosis score results from an international prospective multicenter validation study. George.
Well, thank you very much for the kind introduction and the APA for giving us the opportunity to present our work. I'm going to be talking about the chronic pancreatitis prognosis score, and these are results, final results from an international prospective multicentric study, and I hope that also in your eyes this will conclude the preliminary data we showed 2 years ago at this meeting. These are my conflicts of interest. None of them are relevant to the current talk. So the chronic pancreatitis prognosis score, which you can see on the right-hand side, is the first prospectively developed clinical scoring tool for chronic pancreatitis that our group developed back in 2017 with the aim to design a scoring system that allows to predict risk of hospital admission within 12 months. The score is comprised of 5 easily accessible clinical or laboratory parameters which can be obtained in clinical routine. Each of these parameters is given a point value from 1 to 3 in accordance to deviation from normal, and then these are summed up. So you get a score value of 5 to 15, which is correlated to the risk of hospital admission in the original cohort, and you can also put them in risk categories from A to C, similar to the Child-Pugh-Cott score for liver cirrhosis. The goal of the current study was to validate this scoring system in a larger prospective international cohort to show its robustness. The study design, this was a prospective cohort again, multicentric, with a recruitment goal of 500 patients as per our sample size estimation. We had 15 centers from Europe, Japan, India, Pakistan, and the US contributing. This is the geographic distribution of all patients included. We screened 546 patients during the study period from May 2016 through to September 2019. 51 patients did not meet inclusion criteria and had to be excluded. For all the rest, the COPS was calculated and then they were followed up for 12 months. 75 patients, we did not have enough data to analyze them, leaving us with 520 patients that were included in the final analysis. These are the cohort demographics, which we believe are a fair representation of what all of you see in your daily clinical routine. Median age was around about 50. There's a strong gender male predominance. A little over 1/3 were diabetic. About half of them needed pancreatic enzyme replacement therapy, and about 1/3 was in regular pain. Etiology was predominantly alcoholic and then idiopathics. And the mean COPS score was calculated at 8.2 points, so right in the middle, basically. And we had the largest group in the COPS-B category of a little over half of all patients, and then 20% and 24.5% on both sides. These are the first results, and as the primary endpoint, again, is hospital admissions. To our joy, we see here again a very strong correlation with the primary endpoint, number of hospital admissions for our patients. So the higher the point value of the score, the more likely patients are to be admitted to hospital during follow-up. And the same is true for the combined length of hospital stays. To make this a little easier to comprehend, we have also plotted here the number of hospital admissions with regard to the COPS category A, B, C. And again, there's highly significant differences between the groups with an increasing risk in COPS B and COPS C. What that means for individual patients is shown in the table. So if you look at hospital admissions, and again, this is highly significant in COPS A, there's a 26% chance of being admitted to hospital within 12 months from inclusion. And this risk increases dramatically in the higher groups of COPS B and COPS C. And the same is true for length of hospital stays. So in the COPS A group, patients had only 2% chance of staying in hospital for longer than 3 days during that 1 year, whereas this risk increases with COPS B 8% and COPS C 19%. There's no effect or no correlation to mortality, which was, as expected, quite low because of the short period. So in conclusion, we were able to validate the COPS score in a large prospective multicentric cohort study with patients with chronic pancreatitis recruited from in- and outpatient settings around the globe. And we believe that COPS is a reliable tool to identify especially patients at high risk for hospital admission. I'd also like to highlight that only about 2 months ago, there was another cohort published from an Indian group that is completely independent of this consortium that showed in their large outpatient cohort similar results, and were externally, again, able to validate these findings and further supporting the robustness of the tool. As for future directions, I think the next step in making this available and helping us to learn how to use it in our daily routine, we need to use this tool or this score in clinical use case scenarios to really identify ways how it helps us to guide treatment. So questions that need to be tested in studies are whether or not it helps to identify patients for expert referrals, whether it can help to guide treatment and reevaluate interventions, and whether or not it can be used as a surrogate in clinical trials. The first step towards that goal is that COPS has now been included in a large ongoing prospective trial that evaluates treatment success of endoscopic interventions for chronic pancreatitis in Europe, which has been put forward by the Dutch Pancreatitis Study Group, and we're really happy to be part of this. And in order to help you use this tool, we have now also programmed a little app which is available through the URL of www.cops-calculator.org. And credit goes to my friend and colleague Hans Stube, who has programmed this app in his free time. And I invite all of you to use it. And with that, I'd like to thank everyone involved on the whole consortium, some of which of the PIs are also here in the room. So thank you very much for helping us putting this together. And I'd like to thank all of you for your attention.
Thank you, George. This paper is open to Q&A. Any question?
Just some naive questions from basic scientists. So what was the readmissions for? That was uniformly just an acute attack?
In this study, we didn't really look at the reason for hospital admission. In the identification study, we tried to distinguish between pancreatitis-related admissions and non-pancreatitis-related admissions, and the score correlated to both, so it didn't really make a difference. Additionally, it's very difficult, especially for non-planned admissions, so acute admissions, to really tell is this pancreatitis-related or unrelated, because we know the syndrome or the disease has so many implications also for other organ systems. So I don't think it makes much sense to make that differentiation when using a tool that is supposed to give you an idea of overall disease severity and disease burden.
It also wasn't really clear what this tool is useful for. I mean, for you as a clinician, I mean, are you going to use it really in your daily practice, or this is more like geared towards clinical studies to quantitate things, or what's the utility here?
The idea originally was to give also non-pancreatic experts a tool at hand that allows them to clinically assess the severity of pancreatitis, because that's an unmet clinical need. We don't have a tool to measure that. And hospital admissions were first just chosen because it's a relatively easy, measurable, hard endpoint in this cohort, which we believe is reasonable. But you're absolutely right. We now need to learn, now that we established the robustness of the tool as such, how we can apply it to our clinical practice, and this will be the subject of further studies. Thanks.
Tema Turkis, radiologist from Indiana University. I found it very useful and intriguing. Did you look into any imaging data? Was it any helpful to you, especially MRI, in prognostication of chronic pancreatitis?
We did not as part of the validation study, but we looked at Cambridge scores in the original identification cohort, and there was no correlation with severity on imaging and the endpoint of hospital admissions, so which is why we took it out of the equation there.
Thank you very much. Okay, the next talk is by Junjun Chao, a preclinical model of pancreatic lipase T221M develops chronic pancreatitis through protein misfolding. Jajun is from Washington University in St. Louis.
Okay, good afternoon, everyone. Thanks for the organizer for inviting me to give a talk on a new mouse model for chronic pancreatitis. Which one should I use? And the increased evidence suggesting that the mutation induced protein misfolding may be an important pathway for the development of chronic pancreatitis. Homozygous mutation T221M in PNAPs was linked with pancreatic exocrine insufficiency, probably the chronic pancreatitis in two brothers. Our published data suggesting that human PNAP T221M misfold and trigger ER stress in transfected cells. And to test the hypothesis that this mutation may cause the chronic pancreatitis by protein misfolding, and then we create a knock-in mouse model of PNAP T221Ms, which I will refer as TM in this talk, to determine if these animals develop chronic pancreatitis. So at first, the pancreas forms the TM homozygous animals and show clearly sign of pancreatic atrophies by look at the growth appearance and also the pancreas weight. The phenotype for pancreatic atrophy was less severe in TM heterozygous animals. Based on the H and E stainings, the pancreas from the wild types animals remain normal and healthy from age 1 through 12 months. On the other hand, the pancreas from TM homozygous animals shows the progressive pathological change with age. In the TM heterozygous animals, the pathological change happened at a slower rate. Because of that, the rest of the talk will focus on the TM homozygous animals. The key feature of the pathological change in the pancreas of our TMS, including loss of acinar cells, fatty change, and immune cell infiltration. By immunostaining, we confirm that macrophages are the predominantly immune cells present in the pancreas of TM mice. There are also some increase of the CD3 positive T cell presence in the pancreas of TMS as well. We stain the mouse pancreas with tricrons to assess the fibrosis. Relative to wild-type controls, the pancreas from TMS show substantially increased blue stain indicate of fibrosis, which was further supported by higher hydroxyproline contents. So taken together, the data from the first part of my talk indicate our mice develop chronic pancreatitis based on the phenotype of pancreatic atrophy, losing of acinar cell inflammation, fibrosis, and fatty change. Next, we took a multiple approach to define the underlying disease models in the mice. The first, we immunoblast the mouse pancreas extracts for PNAP. The amount of soluble PNAP was similar in wild type and TMS, whereas detergent insoluble PNAP was detected only in the TMS, indicate of the protein misfolding of this mutant protein. Interestingly, the amount of aggregates decreased with age, and where the disease still progressing. So then the next we determine to determine if there is an increased ER stress in our mouse model, we first use electron microscopy to look at the ER ultrastructure relative to wild types. The acinar cells from TMS show dilated ER and indicate directly indication of ER stress. We then match the gene expression of two major biomarkers for ER stress, BIP and CHOP by qPCR. By the age of 2 months, the MR abundance for both BIP and CHOP are significantly upregulated. So this data is consistent with increased ER stress and the UPR. Then we further look at if there's an increase of cell apoptosis in our mouse models. First, we examine the H&E stain the mouse pancreas and for sign of apoptosis relative to wild-type control, and their increased number of cells show sign of apoptosis, such as the cell shrinkage and the nuclear condensation. This finding was further supported by staining, the staining for the apoptotics, the markers, cleaved caspase-3 and the tunnel, as you see here. One of the interesting things I have to point out here is you see just a very small number of the cells are present in our mouse model, suggesting the ascending cell injury occurred at a different rate. It's not at the same time. So, this part of the data suggesting that the PNAP, suggesting that PNAP T220I misfold in the pancreas, which trigger the ER stress and UPR, and the leading to apoptotic cell death. In conclusion, our TMS develops spontaneous chronic pancreatitis with a hallmark of human disease through misfolding induced the protein misfolding and ER stress mechanism. Just keep in mind, our heterozygous animal developed a very strong phenotype of chronic pancreatitis. So therefore, the TM mouse will be invaluable models to further define the protein misfolding pathway for the development of chronic pancreatitis. Thank you for your time. I'm happy to answer any question you have.
Very nice work. Questions? Eugenia?
I have one question. You say that there is an increase in BIP, or BIP, and then also, of course, SHOP2, and then you say that because of that, you believe that the UPR system is activated. I guess it's not enough to confirm that. I just wonder if you mentioned some UPR sensors to confirm that the UPR system is activated.
Yeah, actually, that's a very good question. Is what we are trying to do now. Is there are 3 arms of the UPR pathways. Yeah, so we are actively involved to interrogate each of the pathways, the major components of the pathway. But one of the biggest problems we encountered is because you imagine this disease is a chronic disease. So also is another thing is involved is we realize the cell population may somehow change. So because it's very hard to use either qPCR or Western blot to quantify. So the best way for us maybe is just do the immunostaining, because as you see from the loss of immunostaining, actually only very few cells they are positive. But if you use the golden method like Western blot, maybe unable to see it. Yeah.
Very nice model and very well presented. Thank you. So this is it. It's strikingly similar to the CPA model we published, and we have another trypsin misfolding model. It looks like it's a sort of a uniform phenotype with very minor differences. So we don't see much of an ER stress either in our models. So that's really puzzling. ER stress is so prominent in cell culture models with these constructs, and you go to the mouse, and they have a little dinky increase in BIP, and that's all. It's very interesting. CHOP is increased much more, but we actually did studies now with CHOP deletion, and CHOP deletion has no effect on the phenotype. So it's very interesting. Quick question: the immunoblast you showed, that's total homogenates or isolated acinar cells?
Is total homogenates.
I think it would be interesting to demonstrate the secretion defect on isolated acini.
Yeah, the problem with that is like in your CP1, the model, the acinar cell is very fragile. Yeah, so when we try to isolate.
So what we did, we actually isolated very early, like 1 month when there's minimal disease, and then you have to use like twice as many pancreas for the mutant. But it's actually, I mean, we are not really a great cell isolation lab, but we could actually manage this, and you can look at cerulein in CCK-induced release of your mutant. That would be interesting to do.
Yeah, so that back to what Miklos was asking about. Actually, another very interesting we found is actually the BIP at protein level is down. Yeah, it's very interesting. Another thing is our heterozygous animals also develop chronic pancreatitis, but the misfolding protein in heterozygous is very, very almost invisible. So we don't know what's caused the disease.
Yeah, along those same lines, if proteins are aggregating, the cell's going to try and remove them. Probably the mechanism is through autophagy, so it'll be very interesting to know if autophagy is compromised in those cells because it's overwhelmed.
Yeah.
Thanks, wonderful talk.
Thank you.
Our next speaker is Carl Lu from Cyclone Pharmaceuticals. Will be presenting virtually. This talk is on immune enhancement to reduce the incidence of infected pancreatic necrosis, a double-blind randomized controlled trial.
Hi everyone. I'm Dr. Luke from Nanjing University, and I'm very sorry that I cannot attend the APA meeting in person this year. So we have to present our choice trial virtually. The choice trial is conducted by the Chinese Acute Pancreatitis Clinical Trials Group, and we're trying to use immune-enhancing therapy to prevent the development of infected pancreatic necrosis, which is IPN. So here's our conflict of interests. It was partly supported by the Cyclone Pharmaceuticals. And for the patients with acute pancreatitis, we all know that they have very different courses. And most lethal cases actually happen in patients with pancreatic necrosis, especially those with infected pancreatic necrosis. And it is a highly morbid complication of acute pancreatitis. So how it was get infected? So it is widely accepted that it's majorly due to the translocation of bacteria from the gut. So several attempts have been made based on this. The most direct one is prophylactic antibiotics. And due to concerns about drug resistance and the potential fungal superinfection, it was no longer recommended in mainstream guidelines. And another trial was probiotics, and it was found to be unsafe with increased risk of mortality due to bowel ischemia. So another point might be the immune status. A Japanese study shows that immune suppression can happen very early and develop rapidly in patients with severe acute pancreatitis. They use a validated marker called HLDL expression, which is used by us in the following studies. And our first hypothesis is that in patients with necrotizing pancreatitis, some of them can develop immune suppression in the early phase, and some of them can get infected due to the immune status. So we did an observational study to prove this, and our results are very similar to the Japanese one. You can see that patients with higher Apoptotic score and with higher grade of disease had a lower HLDL expression. So here comes our second hypothesis. In patients with this kind of immune suppression, if we do some immune enhancement, we may prevent the development of IPN. And as a population acute necrotizing pancreatitis, we may reduce the incidence of IPN. So the drug we chose is samosartan, which can enhance our immune system in different dimensions. It was used in patients with sepsis, with chronic hepatitis. So it was an approved drug. And we did a pilot study first. It was published like 10 years ago. In this single center pilot study, we randomized 24 patients. And we recruited patients within 2 weeks of disease onset. So they're basically in the early phase of the disease. Let's see the results. You can see the incidence of IPN dropped from 29% to 8%. This is really dramatic, and this is like a 70% drop from the control group. And we can see HLDL expression was increased by the drug. So it is very encouraging, and based on the pilot study, we decided to do a confirmatory phase 3 study, which is the choice trial. It was conducted by the CAP-CTG, and we recruited patients from 16 sites. Overall, in total we randomized 508 patients, and you can find more information on our website. which is capctg.medbay.cm. And we have other ongoing trials. So here's some methodology key points of this. The TRACE trial, it's a double-blind randomized controlled trial, and we use block randomization with fixed block size, which is 4. The recruitment of patients finished by the end of 2020. It was like a 4 years recruitment. For the sample size estimation, we conservatively demonstrate a 40% reduction. So in the prior study, we actually saw 70% reduction, and in this confirmatory study, we try to prove a 40% reduction. And considering 4% of withdrawal, we plan to randomize 520 patients in total. So here's our inclusion and exclusion criteria, and we recruit patients within a week from the onset of the disease, and we use Apoptotic score to make some like predict severe patients, and we use brother CT score to make sure every patient has pancreatic necrosis when randomized. So the drug regimen was like 2 weeks, and the first week it's a different dose in the first week and the second week. The primary endpoint is development of IPN during the index admission, and we also did a 90-day follow-up to see if there's any change in the incidence of IPN. And this is our published protocol on BMJ Open in 2020. So here's the main results, and unfortunately, it's overall a negative study. We can see a 2% or 3% drop of incidence in the sampling group, and in 90 days, it was more than 3%, but they are both insignificant. And here's the KM curves for the cumulative incidence of IPN to 90 days. Still, there's no difference between groups. And we have 4 predefined subgroups, and we can see larger effects in patients with great extent of necrosis. But the sample size is not big enough to draw some solid conclusion from this. And all the 4 predefined subgroups are negative, basically. So here's our website and our ongoing trials. Hope that we can build more collaborations through this. Thank you, everyone.
Thank you. Yeah.
I think Carlo is available.
Yeah, I'm here to take questions.
Any questions?
Okay, I don't think there's any questions, so I think we'll move on. Thanks very much.
Thank you. No problem.
Okay, the final talk is by Alexandra Demsak, is that right? Heterozygous SPINK1 deficiency promotes progressive pancreatitis in mice. She's from UCLA.
Thank you for the kind introduction, and thank you for the APA to give me the opportunity to present our data. So the SPINK1, or by its legacy name SPINK3, is a small trypsin inhibitor protein which is secreted mostly throughout the GI system, and its major source is the pancreas. So due to loss of function mutations, the decreased level of SPINK1 can inhibit less amount of trypsin in the body, and that can increase the risk for chronic pancreatitis. However, this was never thoroughly investigated in animal models, and the currently available mouse models are giving contradictory results. So the pancreas of mice which are carrying a homozygous SPINK1 deletion have disappeared progressively after birth. The mice failed to gain weight, and they died spontaneously by 2 weeks of age. On the other hand, the mice which were carrying a heterozygous SPINK1 deletion, they developed normally like the control animals, and they had a normal pancreas structure. So all the experiments in our study and in previous studies have been carried out on these heterozygous mutant animals. So when acute pancreatitis was induced in the heterozygous knockout mutants, the previous groups, they didn't see any differences compared to the control mice. On the other hand, in mice which are transgenic and overexpressing SPINK1, there were definitive proof of the protective effects of SPINK1 on both acute and chronic pancreatitis. So the contradiction is coming from the fact that the reduced level of SPINK1 has no influence on acute pancreatitis. However, when it's overexpressed, it can be protective against both acute and chronic pancreatitis. And none of the previous groups have ever investigated if this could be due to a trypsin-dependent mechanism or not. So our aim in the current study was to investigate the effects of SPINK1 deletion on acute pancreatitis, intrapancreatic protease activation, and chronic pancreatitis. So we generated a new knockout mouse model, which resulted in the complete deletion of SPINK1. We measured, induced acute pancreatitis by 10 times cerulean injections. We also measured intrapancreatic protease activation after 1 cerulean injection. We also followed the disease progression after an acute episode, and we also investigated the course of the disease in the T7D23A SPINK1 knockout cross-strain. So the heterozygous knockout mice develop normally as the black 6 control mice, as seen on the first graph, the SPINK1 mRNA level was about 50% compared to the wild-type animals, and the SPINK1 level was also decreased on a protein level verified by Western blot analysis, and there were no histological differences compared to the black 6 mice until the age of 6 months. So we induced acute pancreatitis by 10 times cerulean injections, and we can see that the cerulean-treated SPINK1 knockout animals have elevated pancreas weight and amylase levels, but it did not show any difference compared to the cerulean-treated black 6 control mice. When we analyzed their H&E stained histological sections, we didn't find any difference between the two strains in the pancreas edema, inflammatory cell infiltration, and in the rate of necrosis. So then we measured intrapancreatic protease activation by giving the animals 1-time cerulean injection, and they were euthanized 30 minutes after that. So again, we saw elevated trypsin and chymotrypsin levels in the cerulean-treated knockout animals. However, it did not show any difference compared to the cerulean-treated control mice. So these two experiments can verify that the SPINK1 deletion has no effect on acute pancreatitis, and these results are in correlation with the findings of previous groups. So our next approach was to follow the disease progression after an acute episode. For this, the animals received 8 times cerulean injections on 2 consecutive days, and they were euthanized on the 5th day. So here we could see that both the cerulean-treated knockout and the control animals' pancreas weight have decreased. However, this was more prominent in case of the heterozygous SPINK1 knockout animals. And if we take a look at the histological sections, we can see that by the end of the experiment, the black 6 animal had barely any damage on their pancreas. On the other hand, the knockout animals developed chronic pancreatitis-like features, and they had a more prominent acinar cell atrophy as well. So then we went further and we crossed these SPINK1 heterozygous mutant animals with the trypsinogen activation peptide mutant D23A mutant animals, which was previously also shown by Professor Sehintot. So these animals develop a really early spontaneous acute pancreatitis, which then rapidly progresses to chronic pancreatitis due to a robust trypsin-mediated trypsinogen activation. So when we cross these two animals, the pancreas weight significantly decreased compared to the control mice and the single mutant counterparts. And if we take a look at the histological pictures, we can see that they had either severely damaged pancreas or completely damaged pancreas, while at the same age, the single mutant D23A mice had either normal pancreas or acute pancreatitis. So to summarize our data, we can say that the reduced SPINK level has no effect on cerulean-induced acute pancreatitis and intrapancreatic protease activation. However, the SPINK1 knockout heterozygous mutant animals are more prone to develop chronic pancreatitis after an acute episode, and the SPINK1 deficiency is increasing the disease severity in the T7D23A mice. So in conclusion, we can say that the heterozygous SPINK1 deficiency promotes progressive pancreatitis in mice in a trypsin-dependent manner. And thank you for your kind attention.
Very nice talk. It's open for questions. No one? Here we go.
Hi. Great talk. My question is, you're talking about only very specific cerulean-induced acute pancreatitis model. Did you try other models also, like duct ligation? Doesn't show effect there also?
No, we did not try any other models, but it's a really good
worth
advice.
to try
Maybe we
kind of
could
thing.
try.
Maybe they have like in other models, can you see different effects kind of thing?
Yes.
Thank you so much.
Thank you.
I have a technical question. How do you measure percent acinar cell loss?
So I submitted every time the whole pancreas. So this way I try to kind of avoid bias that I cut out the pancreas section and it's not evaluated.
Sure.
And then, so we considered as 100% is the whole size of the section that I see on the slide. And then basically it's kind of arbitrary, so it's by my eyesight. So what I do is I always do all the sections at the same time, so it's not like on the other, like the next day I wake up and I want to, evaluate it in a different way. So basically, it's a ratio between the damaged area and the whole area that I see on the slide, and that we express it in percentage.
Perhaps I can get your email. Thank you very much.
Thank you.
Appreciate it. I'd like to thank all the speakers. Thank you all for coming. There's an announcement up here that this evening's reception has been moved to the Mona Lisa Ballroom, which is off the main lobby on the Nobu side, starting at 7 p.m.